Hello, good afternoon, everybody. So we're going to talk today about managing fluid and electrolytes in conjunction with your home parenteral nutrition. And you can see I am Albany Medical Center, I'm located in Albany, New York, and I'm taking care right now of maybe 75 to 100 patients that are on HPN, home pen or enteral feeding as well. Next slide, please. So I don't have any disclosures, but I should mention that I do speak for Takeda on short bowel syndrome and management. Next slide, please. So just a brief overview. This is what we're going to try and cover today in the half hour that I have. So I'm going to try and help you understand a little bit about hydration. We'll talk about how you can get into trouble with dehydration, how you recognize that so that you can address it if it's occurring. And then I'm going to go over a little bit about how we manage the fluid and electrolytes for patients with short bowel syndrome, and then briefly just give you an idea of when it might be best to call. If you're concerned and you've recognized using some of the tools that I'm going to show you today that you might be becoming volume depleted, when you should call, and just some guidelines about when to involve your physician if you think that you're getting into trouble. Next slide. So hydration is basically talking about your body's management of water and sodium. So hydration, when we talk about it in our body, is not just water. When we drink water, we do provide hydration, but in order to hold on to that fluid, we need sodium. So when we talk about hydration clinically among physicians and other caregivers, we know that we're talking also about how much sodium the patient is getting in addition to how much water they're getting. And some of the things that we use to look at that is we look at your sodium concentration. Sodium concentration in your blood gives us an idea of how water and sodium are balancing with each other, but not necessarily how you're doing totally with your fluid. So when we talk about losses of fluid, things that cause us to lose water are urine, sweat, and stool. So when you have a short bowel, the most predominant source of fluid losses is the stool, because we talk about diarrhea. And as Maria talked about earlier, that's one of the main symptoms and one of the things that we try and manage the most to improve your quality of life. So that's one of the reasons why you need the IV, is because you're losing more fluid than you can absorb. And then we talk about sodium or salt. When we talk about sodium, we're basically talking about what you may think of as salt. Table salt is sodium chloride. So water alone won't maintain hydration. Now, if you're drinking water and you're losing salt, your kidneys, if they're functioning normally, will help to retain sodium, and so help your body to retain the fluid that it needs. But if you become dehydrated, and this goes on for a prolonged period of time, it can actually cause injury to your kidneys. So over the long period of time, if you have dehydration for a prolonged period, you can actually see a decline in kidney function. And so the kidney may not be able to adjust as well to the fact that you're not getting the fluid that you need. Next slide. So how do we get into trouble with dehydration? So one reason, of course, is that we don't have enough fluid intake. And in people that don't have short bowel, that's the most common reason why they get into trouble with dehydration, because they don't have a lot of excessive losses. They don't have diarrhea on a regular basis. So that's most of us, if we get into trouble with dehydration, is because we're not taking in enough fluid. But for folks with short bowel syndrome, fluid losses from diarrhea become one of the biggest causes. Now, if you have vomiting for any reason, of course, you're losing fluid from vomiting as well. And some of our patients with short bowel may have tubes or drains if they've had fistulas or abscesses that are being drained as a result of procedures that they've had. You're also losing fluid from those sources. You need to be aware of sweat losses, even in a normal environment with normal humidity. We're losing a bit of fluid through our skin on a daily basis. If it's very hot weather, obviously we're losing more fluid. And if you have a fever, you're losing an additional amount of fluid. So in a setting with a fever, your fluid losses are going to increase, and you may not necessarily be aware of those. In some settings, you can lose fluid due to increased urine output. This is relatively uncommon. If you have high sugar in the urine, so in a patient who's diabetic and you're secreting glucose, that glucose is pulling water out with the urine. But in most situations, you're not losing excess fluid through the urine. In fact, the kidney is going to try and hang on to more fluid as you become dehydrated to try and prevent you from becoming dehydrated. So the kidneys are actually trying to help compensate for the fact that you're losing fluid in other ways. Next slide. So when we talk about dehydration, what kind of manifestations might that have? So first of all, you want to be watchful for any increase in stool volumes. So all of you have probably with short bowel have significant fluid losses from your stool on a daily basis. You're kind of used to what the day-to-day fluid losses are going to be. And so if you see a change in that and suddenly you seem to be having more diarrhea than your baseline, that's something that you want to kind of make a note of and make sure that that's not going on for a prolonged period of time. Certainly if you start vomiting and that's not something that is on a, that is part of your day-to-day symptoms, that's something that is going to cause you to lose fluids. And then be aware of sweating, the ambient temperature, if you're outside in the heat or if you have a fever. And one of the things that we talk about sometimes is whether or not folks should be measuring stool. And it can be helpful in certain situations. In the early stages of being discharged from the hospital after the event which has led you to have a short bowel syndrome, sometimes the stool volumes that we're seeing in the hospital don't necessarily carry over to the home setting. You may be eating different things, certainly your activity is different, etc. And so your stool outputs may change a bit. Certainly if we're adding new medications that we're trying to decrease stool volume, it might be helpful to have you measure your stool. We're not talking about doing this forever, but it can be helpful to your care team to know if there's a significant change from day to day in the amount of stool that's being produced. Symptoms of dehydration would, for example, be feeling lightheaded when you're standing up. When you lose excess fluid, your blood pressure may be lower than your baseline blood pressure, so that when you stand up, it's taking a while for your body to get that blood flow back up to your head. And so you're feeling a little dizzy when you stand up quickly. That can be a sign that your fluid volume is a little bit low. It can also manifest just simply as feeling fatigued or more sleepy than normal or exhausted. And that may be a sign that you don't have enough fluid on board. Certainly increased thirst can be a sign of being dehydrated. But I should point out that part of having a short bowel is sometimes associated with having increased thirst just at baseline. So that may not necessarily be as good an indicator in a person who has a short bowel as it would be in someone who has a normal bowel. Keeping an eye on your urine volume is also another way to kind of monitor your fluid status. And again, measuring your urine volumes may not necessarily be something that you need to do all the time, But when you first come out of the hospital, or if there's been a change in your medication or a change in your TPN volume or your hydration volume, watching your urine volumes may be a helpful guide for your care team as to how we're doing with hydration. So what we look at is how much urine you need to make, and that depends on your age, your weight, your height. So it's all individualized. There's no standard amount of urine that you need to make. But if you become dehydrated, your kidneys are going to start trying to conserve fluid. And so the amount of urine that you're making is going to go down. So if you see a decrease in your urine volume, that can be an indicator to you that you're becoming dehydrated. Certainly your urine may become darker because as your kidneys are trying to concentrate that fluid more, they're concentrating the urine, and so the urine looks darker to you, maybe becoming more yellow or even orange. Other symptoms that are somewhat nonspecific are having headaches, more muscle cramping or muscle weakness. You can see an increased heart rate, and that's part of the fact that your blood pressure may be a little bit low. So your heart is needing to pump more times in order to circulate the volume that you have left. And then in end stages, like if you let this go on for a longer period of time, you can see confusion, and even patients can have seizures or go into a coma if they become severely dehydrated. So we obviously don't want to let things get to that point. So you want to make sure that you're monitoring these other symptoms. Next slide. So one of the signs that is a physical test that you can do is if you take your forearm and you pinch the skin should bounce right back, should be pretty elastic. If you become dehydrated and you pinch the skin, you'll actually see that the skin stays in a little tent there and it doesn't bounce back. So that's what we call tenting. And that little pinch test can actually be a clinical sign that you can test for if you're worried that, jeepers, am I becoming dehydrated? Now, this doesn't happen early on. So if you're having a positive pinch test, you're pretty far along in terms of being dehydrated and somebody you should be calling your care team. Next slide. Okay, so now we're going to talk about how do we maintain our hydration. So first and foremost, we want to try and decrease diarrhea. And so Maria spent a lot of time earlier this afternoon going through some of the things that you can do to try and reduce your diarrhea. And that's why I say it takes teamwork. So if you're doing the right things in terms of what you're eating, what you're drinking, the pace of what you're consuming, you're not chug-a-lugging your liquids, but you're sipping them slowly through the day, that's going to improve your absorption. Certainly the medications that we're using are going to help. We talked about, Maria spoke about using loperamide or diphenoxylate. That's medications to try and improve your opportunity to absorb fluids by slowing it down as it's moving through. And then using your oral rehydration solutions. So all of those things are things that you're doing. We're prescribing medications, obviously, and then we are going to try and provide adequate fluid volume to you to make up for the difference. So you're doing the best that you can do with your diet, with your fluid intake, with your medication compliance. And then it's our job to make sure that we're keeping up with those losses that you're having as a result of the diarrhea that is still there, even after you're doing all the things that you can do. So we're working as a team together. You do your part, we do our part, and hopefully we don't end up with dehydration. So when we talk about fluid volume, what we're looking at is how much fluid do you need? Okay, so there's two parts to that. One is the maintenance fluid, and then the other is the replacement fluid. So we're trying to replace the extra fluid that you're losing from diarrhea, mostly from diarrhea, but from any source, from vomiting, from diarrhea, from tubes, from drains, those types of things. Next slide. So maintenance fluid. So what is the maintenance fluid? So maintenance fluid is the daily provision of fluid that we give you that is needed for normal metabolism. So whether you have short bowel or you don't have short bowel, we all need to have a certain amount of fluid just to run our metabolism. And it's based, again, on our age, on our weight, and it's calculated individually for each person. So there's no two people out there who have the same exact requirements. But pretty much as we're going through our life, we may need to adjust as we get older, depending on how much activity we're doing, whether we're out in the heat or whether we're staying in our nice air conditioning. Our fluid losses are different, and so that's something that we take into consideration when we're making our prescription for your fluids. The fluids that we provide are also going to provide you with electrolytes. And I'll talk a little bit about electrolytes, and I can answer individual questions as well. But that's how we're providing for the electrolyte losses that you may also be experiencing as a result of your diarrhea. Next slide. So now the replacement fluid. Okay, so the replacement fluid gets added onto the calculation that we make for what we believe to be your maintenance fluid. And okay, so wait a minute. My computer just dropped me out. Okay, so mainly, again, in short bowel, these extra losses are coming from your bowel. So your losses are going to be dependent on how much bowel you have, so the bowel length that's left, the function of that remaining bowel. So is that bowel that's remaining, is it normal? Do you have Crohn's disease, and is there still some activity from Crohn's disease in there? Is there stricturing in there? Some patients may have radiation damage to their bowel, and that's what's caused them to have the short bowel. And so some of their remaining bowel may not be functioning normal because of the radiation effect. And then the other factor is which bowel segments do you have that are remaining? So depending on where in your along the course of your bowel the segments were removed, that can also affect whether you're losing more electrolytes, what the concentration of electrolytes that you're losing consists of. And so in the early stages, primarily, when you first had these resections, we need to monitor quite closely to determine what your requirements are. So that's when we, again, may ask you to do some stool and urine volume measurements. Certainly while you're in the hospital, our goal is to get accurate measurements of your stool volumes and your urine volumes. Now, sometimes that's a little bit difficult. If your bowel is in continuity all the way to the rectum and you're having a lot of diarrhea, sometimes it's difficult for us to actually get separate collections of stool and urine. So if it's mixed together, it doesn't really help us all that much. But we also are looking at your blood electrolytes while you're in the hospital, and we're trying to adjust your TPN or hydration formula to reflect what you need. And so, and that's all that's going on prior to your going home from the hospital. Now, once you're home, it doesn't stop. We continue to monitor your blood electrolytes, and we continue to modify your fluid volume as based on what we're seeing happening after you're home. So next slide, please. So now I'm going to talk a bit about electrolyte losses, and I'm not going to go into detail about this because it can get pretty complicated, and it's basically quite individualized. But when we talk about electrolytes, what we're talking about is sodium. Okay, and again, sodium basically is salt. Okay, potassium, which is another salt that actually, if you use salt substitute, instead of the salt substitute being sodium chloride, it's actually potassium chloride. So that's where you can get some potassium. Potassium is excreted along the length of the bowel, and it gets reabsorbed as well. So again, everybody's potassium losses are quite individual, depending on what your bowel anatomy is. Magnesium, the same. So magnesium is another electrolyte. It's secreted by the bowel, it's reabsorbed by the bowel, and your losses, again, will depend on your remaining anatomy. So those three electrolytes are what we call anions, A-N-I-O-N-S. That means that they have a positive electrical charge. And I don't want to get too complicated about this, but every anion needs to have a cation, which is C-A-T-I-O-N, and that's a negatively charged particle. So whenever you see potassium or sodium or magnesium, they all are part of a salt. Okay, so it can be sodium chloride, it can be sodium bicarbonate. Okay, it can be potassium chloride. We don't have potassium bicarbonate available to us, but we use acetate in parenteral nutrition to provide bicarbonate. So acetate in your TPN formula is a way for us to provide bicarbonate, because your liver will convert the acetate into bicarbonate in your system. And so that's a way for us to replace losses of bicarbonate that you may be having from your intestine. So bicarbonate is produced in the intestine, it's produced by the pancreas and secreted into the intestine. If you don't have a short bowel, it's generally reabsorbed, but it may not necessarily be reabsorbed in a short bowel. And so you can have fairly high bicarbonate losses. And we replace these in your parenteral nutrition formula as acetate. And magnesium is provided as another salt, predominantly as magnesium sulfate, which is sulfate is another negative salt, or it can be magnesium chloride. Next slide. So I hope I'm not getting too complicated, but what I'd like you to realize is that your stool volumes can be quite high. And you may think to yourself, well, I'm only taking in a couple liters a day. How can I be putting out 4 liters of fluid? So if you look at the left side of the slide, that's all the intake. Okay, this is what's going into the bowel. So first of all is what you're eating and drinking, which, you know, most people is about 2 liters a day. We probably would encourage you to do a little bit more if you're having diarrhea, again, using your oral rehydration solutions. But even just your salivary secretions, the saliva alone can be 1.5 liters. Okay, so all of this, the bowel is secreting as things go along. And the more you eat and the more you drink, the more we stimulate secretions. Okay, so if you look at gastric secretions, so in your stomach, 1,500 milliliters. So now we've only gotten down to the stomach and we're already up to 5 liters. Okay, the liver produces bile, the pancreas secretions, another 2,000 there, and then through the course of the intestine, another 2 liters are secreted. Now, if you look over onto the right side, you'll see that reabsorption in a normal small intestine takes care of pretty much a good proportion of all of those secretions and what you've consumed, so that by the time we're getting down to the colon, we only have about 1,200. The colon secretes maybe 200, and in a normal colon, you're going to absorb, 1,250 or so. So when you get to the end, you only lose 150 milliliters. But as you can see, when you lose a segment of that small intestine, you lose a pretty significant capability to reabsorb fluid. So, and again, knowing what your stool volumes are helps us in terms of knowing how much we need to replace. So if we look at it from the standpoint of where is my bowel resected, how much of my bowel is resected, and then the functional capacity of the remaining bowel, you can see how you could end up with a fairly sizable fluid output over the course of the day. So next slide, please. So when we talk about replacing electrolytes, then it clearly is a very individual proposition. So nobody out there has the same exact formula, same exact electrolyte losses. And really what it requires is our ongoing frequent monitoring of what's happening in your plasma. So we look at it and we can tell, okay, your magnesium level is going down. Okay, we're not quite keeping up with your magnesium losses. Conversely, we see your magnesium level going up. We know that we're kind of getting ahead of you. So all of that is, up and down until we kind of get to an equilibrium where we're seeing, week after week, month after month, that things are pretty stable. We're not making a whole lot of changes. And at that point, we can start stretching out the frequency, the intervals between how often we're doing the monitoring. So once people become stable on their formula, we're not seeing any changes in your anatomy, you're not going into surgery again, then we can kind of decrease the amount of times that we have to take blood, basically. Next slide. Okay, so if you suspect dehydration, when do you want to give us a call? So the basic thing is that if you start to see it and you're, some of the early stages, you can sort of recognize it and go, oh, maybe I need to, start sipping a little bit more of my oral rehydration solutions. Okay, that may take care of it. But if that doesn't improve the symptoms, that's when you should start thinking about letting your care team know that maybe I'm getting a little bit dehydrated. Certainly, if you don't see any urine output, and this goes on for longer than 8 hours, you need to call somebody, because that means that you're so dehydrated that your kidneys aren't making urine, and that you need fluid, right now, immediately. Okay. Lightheadedness can be, another progressive sign. Certainly if your blood pressure is low, if you have a cuff at home, good to check it when you're thinking you might be dehydrated. Your skin can get cold and clammy because your blood pressure becomes low, and you're not perfusing, you're not getting blood flow into your arms and your legs. So your body may start to recognize that you're in trouble. Certainly the pinch test. Okay. If you're tenting, then you're pretty far along in the dehydration process. So you need to let somebody know. And by all means, if your symptoms are persistent and you're trying through a 24-hour period to see if you can correct things and they're not improving, then don't wait longer than that 24 hours. Contact your care team, let them know that something, you're not feeling well, that you think you may be dehydrated, and so that they can intervene.